Hello and welcome to the Econ Buff podcast. I'm Lee Stitzel. With me today is Dr. Neil Meredith, Dana Professor of Business at West Texas A&M University. Neil, welcome.
Thanks for having me out there, Lee. Look forward to talking with you.
So our topic today is going to be Medicare for all. So I'm really excited because, a lot of times you get people, let's do a podcast, let's have some interesting conversation, and, they want to shy away from some of those topics that could be a little more contentious. So I'm really excited that you've agreed to go right for it. Let's talk about what's going on in American society today. Of course, you're a health economist, teach health economics, and research in health economics. So I have a bona fide professional here, so I'm very excited about that. A little bit unfair of me to ask you this, but I just want to set the tone, set the context, set the scene for our listeners, because not all of us are the level of expert you are. Help us understand just sort of how you view, not trying to do anything else, just how you view the overview sort of the state of American healthcare right now. Huge question, I know. But
right. Huge question. Some big talking points I guess I would give you with that, just as a general answer, is, there are some problems with the system. That's sort of always going to be the case. There are always going to be problems. But there have also been some serious successes with the system. So if you go back, over the last 100 years or so, you get, the invention of vaccines. You've got public health movements for sanitation, refrigeration, those kinds of things. You've got surgeries and procedures and medicines and things that we can do now that we couldn't do, say, 20 or 30 years ago. So there have been some real advances. The listening audience out there, I don't want you to think I'm just giving you fluff. Take something like Prevnar 13, which, is a vaccine against pneumonia that, is a better vaccine than Pneumovax, I think, that preceded it. Or you take stuff like Sovaldi, blockbuster drug. It literally cures different types of hepatitis C. We've had advances in treating HIV, to where HIV is no longer really a death sentence. Especially if you get in there and treat it early. There's been a lot better control with that, and not just here in the U.S., but also worldwide. And so there have been some successes, but there are also some very loud and significant failures when you're talking about healthcare, because it's a life and death subject. So, other areas of economics, all due respect to them, if you don't like the hot dogs you buy at the grocery store or something, you live for another day. You try a different hot dog, or your hamburger or chicken, or maybe you try some, new no meat substitute or something like that, right? Like Beyond Meat or something like that. But with healthcare, depending on what it is, if it's something like quadruple bypass, if you don't get it, you're dead. Right. Game over. I mean, so it has a different, feel to it because of that life and death nature of some of the, impact that American healthcare can have. So I sound like I'm just driveling on and on.
No, you're doing great. That's exactly what I was looking for.
Okay.
So, I think that sets us up nicely to kind of frame what it is that we wanted to talk about today, right? Because I don't think there's any denying that sort of the progress and the success of medicine has been amazing, right? And so it's almost like the science, and correct me if I'm wrong here, it's almost like the science of medicine is going so far.
Yes.
And the economics of medicine is proving to be, I won't say the problem, but a principal problem here. So that's exactly, that's perfect. I was kind of interested, you talked about, antibiotics, vaccines, those are among the biggest things.
Sure.
They're less than 100 years old.
Right.
So those are phenomenal inventions. And so maybe we'll touch on that as we go. Can you briefly just sort of talk about medical research and invention, and are there trends in that? Is that something that we're talking about in this field?
Sure. So, now we have We've got more diagnostic equipment than we've had before. So two big pieces of equipment there. We typically look at, research-wise, prevalence of MRIs, magnetic resonance imaging equipment, also CT scanners. The prevalence of those in the United States is actually pretty high compared to elsewhere in the world. And so we actually have more readily, we have better access to those sorts of sources. And that's not cheap. So that's one of the features of the actual healthcare system right now that's actually expensive. But people don't want to have to wait to get their knee imaged or their brain imaged or whatever else it is, that can help us improve our diagnostic care and those kinds of things. There's been a lot of research. Health economics research has really taken off in, say, the last 20 to 30 years. The subfield has grown. For example, the American Society of Health Economists, which I belong to, has gone from having a biannual conference to an annual conference. And that conference only started maybe about 10, 15 years ago. And so there's just been huge pronounced growth. About one in every $5 of GDP, a little less than that, but almost one in $5 in GDP is expended on healthcare. So it's almost about 20% of the macro economy. So there's a lot of activity. There's a lot more expense going on there. You can see a lot of growth in healthcare administration, especially over the last 15, 20 years. So there's been a lot of development. I don't know if I'm answering your question or I'm getting a little off track there.
Yeah, you're right on target there. And you've hinted at something that I was going to spring on you later, so we may have to circle back around to this. But the access to this kind of technology, the ability for us to sort of have it on demand, and we spare no expense in American medicine in a lot of ways. I think that's a huge component of the answer as to why prices are so high.
Sure.
And then you immediately transition it, and therefore a large part of the economy as well. And so we're not doing a macro podcast. Thank goodness we're both micro guys in here. So we won't go into the components of GDP there, but it does speak to the question. The dimensionality of this problem is enormous. The importance, the stakes couldn't be higher in a lot of ways. I do a lot of local public policy type research, and I think my stuff's important, but then you sort of step back and go, okay, well, what's the difference between this and doing health economics? So I think that sets the stage really well. So what I'd like you to do now is just kind of give us a brief understanding of what is the background for, and then what is the proposal as, okay, solution to these kind of... Let me ask a specific question first, actually.
Sure.
And then we'll transition into that. Do you think the way that we're talking about things and the problems that we're trying to fix, are they fundamentally price and expenditure type problems? Are they fundamentally addressing market failure? Are they fundamentally how do we improve people's access or outcomes? So there's lots of ways we could think, well, the American healthcare experience could be improved if more people had access. The American healthcare experience could be improved if more people had better outcomes. And the American healthcare experience could be improved if we got the same kind of productivity for lower price, right? If we had, and so as you and I know, and hopefully the listeners will grasp, a lot of those problems are interrelated.
Sure.
The more access you want, the better outcomes you get, the higher the price is going to be, and so on. Right. So can you set the stage for us for this Medicare for All proposal? Is it trying to fix all those things, one of those things, a combination thereof?
I can't speak for, Bernie Sanders or for Elizabeth Warren, who are really pushing Medicare for All right now in terms of all the different problems that they're expecting to address. I think what they're seeing is a lack of access. I think what they're seeing is perhaps, you save on administrative costs. I think what you're seeing is also an ethical discussion of, is medical care something that should, if you can't pay for it, or if you happen to fall in this, sort of between stage place where you don't qualify, you make a little too much money to qualify for Medicaid, but you don't have a job such that, you qualify for private insurance. Maybe you live in a state that hasn't expanded Medicaid. And so you're sort of caught in this no man's land, and they don't want you to be caught in that no man's land anymore. They want you to have insurance coverage. So I think it's in my opinion, it's a heavy-handed solution to any of a number of different issues. So you could look at issues like access. You can ask issues of equity. Is it fair? You can ask questions about, are people losing mobility in the job market because they're having to keep a job they don't want because they can't take their health insurance with them because their health insurance is tied to their job.
So can I derail you briefly? Mm-hmm. That's a previous episode of this podcast is labor mobility.
Yes.
And so that's something I'm eminently fascinated in. We did not mention, I don't think, when we were exploring that topic, not pretending like I have a lot of answers there, but just sort of the exploration. I don't think we mentioned healthcare. Do you want to talk briefly? Does you feel dive into that?
Yeah, we can dive into that. So employer-sponsored healthcare is actually a pretty sizable portion of the insurance market in the United States. We're sort of unique in that regard. Sort of an accident of World War II that there were these wage and price controls in place at the time during the war. And employers said, hey, how can I attract better employees if we've got these wage and price controls? Well, hey, how about we put this fringe benefit in of health insurance? It's this new thing we've put together. And U.S. government said, sure, and we won't tax it. And so, that just sort of then became its own thing that has just morphed into one of the biggest tax-free benefits that American workers receive right now.
So when you go for an interview and then you come back and tell your friends, the second question they ask you is, well, what are the benefits like?
Yeah, what are the benefits like? And one of your biggest benefits is your health insurance coverage, that while you may not see it come directly out of your pocket, your employer is probably paying a sizable portion of your premiums on your behalf because they're incentivized to do so. And it's been recently estimated that, the cost of an insurance policy for a year is about $20,000. Wow. So we're not talking chump change here. We're talking serious amounts of money. And the problem with the employer-sponsored health insurance is that, what if you don't like your job? Well, what if it has really good health care? Yeah. And this other job you're looking at, maybe it's a startup firm or something else like that. You can't leave. You get stuck in this situation we call job lock. Yep. And economists across the board don't like it, whether you're conservative, liberal, or whatever. Yes. We don't like this job lock thing because it's keeping people from moving into where they presumably would find themselves a better fit in the labor market.
Well, that's two-prong, right? Which is, the economist is going to point out that's misallocation of resources, job lock, right? So that's the classic story. But you've already mentioned equity today.
Yes.
What if you want to be in the job where the options are better, that you like the job itself better, but this healthcare thing is just something you can't overcome? So I think that's a phenomenal point. So is the mechanism sort of as straightforward as I would imagine in that scenario where you say, okay, I have benefits in this job, now I go to switch jobs or move to a different geographic area and find a job, and that's just one more thing that's a barrier to me finding a job that fits my needs?
Precisely, yes. Especially if you are somebody who, if you've got a significant medical condition, you may be concerned about pre-existing conditions and those sorts of things. Now, if you've maintained continuous insurance coverage, that shouldn't be an issue for you because the laws are already written, so that should not be an issue. But it slows down mobility. And, you can find news articles out there where you can find these anecdotes of people saying, I'm not leaving my job because of the health insurance benefits. Yeah. You may have a health insurance employer. You may have an employer with a health insurance that is such that, it has to be regulated by your state. Or you may be employed by an employer where its insurance regulation actually is, beholden to some other federal law or something like that. There are idiosyncrasies within that sort of stuff. Generally speaking, people who are in the state, your state ends up being the insurance body there ends up being the regulatory body, but not always the case. You might be working for the federal government office in your state, and your rules for your insurance and what it must cover may be subject to federal government policy rather than the policies of your state, and that may or may not be more generous or less generous depending on what it is.
And those idiosyncrasies are a decreaser of mobility.
Right.
That in and of itself is a cost.
Right.
Okay, so thank you for indulging me on one of my pet interests. So I want to sort of turn it back. Can you set the stage for us a little bit? You've done a good job. You've laid out what proponents of Medicare think they're solving, and I'm really glad you mentioned like the equity and the fairness component, because I think that's a big part of how they're selling it.
Right.
Can you give us a Cliff Notes version of sort of what is Medicare, and maybe why we think that would be a solution to some of the problems?
So Medicare, as it currently is the government-sponsored medical insurance provision program for people who are 65 and over, or people who have renal disease, kidney failure. And so if you fit in that category, you get notification from the government, and they're going to cover a large part of your premiums and costs and those kinds of things for your health care. And it's financed through payroll taxes. It's a pretty sizable program. It's pretty popular. It came about in the 1960s under the Johnson administration, along with Medicaid as well. Medicaid being for the disadvantaged, lower socioeconomic status, and or disabled program there that is financed by the federal government but carried out by the states. So Medicare has getting back to Medicare, it has 4 parts. There's Part A, which is hospital insurance. That covers your hospital sorts of care. Part B is for physician office visits you can think of. Part C is sort of an interesting sort of private-public partnership sort of thing where you can opt into Part C if you wish, and it will cover your hospital and physician stays, sometimes even prescription coverage too. Part D is specifically prescription coverage, and that was brought in by the George W. Bush administration in the earlier 2000s as a way to start covering prescription drugs. So it's quite an amalgamation of all the different options in there. And Part C alone has so many different options in it that people have even done studies trying to figure out what particular health plan within Part C is the best fit for somebody given what's going on with them. And even experts can't figure it out with all the different choices that are in there. That's sort of a little aside. But Part C is sort of an interesting thing because you have private companies that have to meet certain targets that are set by the Medicare program that can offer plans then. And you can take and opt to do that rather than do traditional Medicare.
Oh, so say that last part again. Different firms have to meet certain standards?
Well, so a private insurer who participates in Medicare Part C, they have to meet certain standards that the government sets. So the government pays a lot of the tab, but the actual day-to-day of administering and carrying out the health insurance is carried out by the private entity.
So most of Medicare is direct. Government to...
I couldn't tell you that off the top of my head. I believe that the majority of people participate in traditional Medicare rather than Medicare Part C, although there is a growing portion of Medicare Part C for sure.
Well, so the Part C mechanism would work like the government pays on my behalf to the insurance, and then I deal with the insurance company, and the insurance company deals with my medical providers?
Right. So the government's sort of the financier, so to speak, but more of the day-to-day is carried out by the insurer.
Right. Oh, so that leads to a lot of interesting questions in terms of when you're tackling that, how is the administration from adding the insurance party in there? How does that change the medical experience? How does that change the costs? How does that change, sort of the clarity of options for the potential patient.
Right.
So I assume there's been a lot, or probably burgeoning research on that. I assume.
Yes. So
Any kind of general insights you can give us, or
when you talk about insurance in healthcare, you really are talking about third party payment.
right?
Other types of insurance, like say your car insurance, you really only kind of use it when there's a wreck or someone, bangs into your car or something like that. But you don't use it maybe for your routine sorts of things like getting an oil change, stuff like that. Whereas health insurance, as we know it, is more third-party payment. We use it for everything. We use it for the office visit. We use it for going and getting our prescription filled. We use it for going and getting our flu shot, which FYI, please go get your flu shot out there, listening audience. There's a lot more. You think of it more of just third-party payment because you're basically setting up the insurer to take this big third-party role in healthcare.
I've seen some economists argue calling what we call health insurance is a real misnomer. And I think I hear some of that element in your argument here to say, when I properly think of insurance, I handle all of these things day to day, and if we meet a certain set of catastrophic conditions, it triggers that, right? If my house burns down, house insurance, right? If I crash my car insurance. Health insurance is sort of nothing like that.
Mm-hmm.
And so this is where the element, so for our listeners at home going, okay, well, what's the important difference between insurance? Because they're going to have a good ability to think about what insurance is.
Right.
And then you're making a very important point, which is very common, I think, in the field, is to say, okay, this is that third-party payer thing that we're talking about. Can you sort of tie those two ideas together for us?
Right. So traditionally, insurance, you're trying to purchase a product that helps you address risk. In health insurance, we sometimes also talk about it in terms of addressing lost income. Okay. But traditional view, you're trying to address risk and reduce your risk by buying insurance. So when you buy your homeowner's policy, you're trying to reduce risk of, what if my home burns down? Now, with insurance in healthcare, this third-party payment, it's culturally taken on this, momentum of, when I go to the physician, I expect to not pay X amount out of my pocket. And if I pay X amount out of my pocket, I'm going to be mad about that. And it's like, okay, but if you don't pay X amount out of your pocket, how do I know that you're not going to the physician too often? Of course, that runs into a real uncertainty problem, which, again, insurance is also there to address the uncertainty. You don't want to introduce so much when you introduce a lot of uncertainty, you're running into a quagmire problem, right? So let's say you don't want to go to the physician too often. But yet you also get advice that says, hey, if you've got the flu, let's say, for instance, because we're in flu season, you need to go and see the physician right away. Right? Otherwise, we can't use this Tamiflu stuff to help you.
Yeah.
So then you're like, well, am I really that sick? Am I not? Do I go? Do I not? And you don't want to create a lack of insulation from some of these costs and some of these things because it can have real nasty consequences. So if you insulate too much, though, then you can get overuse. If you don't insulate enough, you get underuse. So you want to try and find this Goldilocks amount of healthcare that gets used, right? So you just let me tell you an anecdote, okay? So I know somebody who doesn't have the greatest insurance policy right now, and that person didn't go and get a shingles vaccine. Said person ended up getting shingles because said person didn't want to pay $170 out of pocket for the shingles vaccine. Now, if said person had an ACA compliant sort of, an Obamacare sort of era healthcare policy working for, an employer or whatever, then the shingles vaccine would have been covered zero cost out of pocket, right? So that person then, because they were not insulated from that cost, they felt the pressure from that and didn't get the shingles vaccine. Well, that person, is regretting that they didn't get the shingles vaccine,
Yeah,
right?
shingles very
So
painful, very
it's very
debilitating.
painful. But there are some sort of, quote, these essential health benefits that came along with the ACA, which is the Affordable Care Act for short, because you want people to be getting routine vaccines. So no, we're not going to charge you anything out of pocket, because when we don't charge you out of pocket, then you tend to use the thing more, right? And if it's something like a vaccine that's been shown to be extraordinarily cost effective and really, really safe medicine, you really want people to consume that. You don't want them to feel any hesitancy of getting a vaccine. So I'm getting a little long-winded there, but
I think
yeah.
you're cutting right to the heart of one of the things that we want to talk about.
Right.
So I don't worry about people over-consuming shoes or steaks or bottle of water, because there's the rationing mechanism that is a market with a market price that provides how do we allocate resources both in productive efficiency and allocative efficiency. So how do we do it in a way that makes best use of resources and also matches the preferences of people, right? So that's the beautiful part of a market. And if you take anything away from econ classes, we hope that's what you would take. So now you're highlighting that issue. If we step in with third-party payer, I'm going to avoid the word insurance for a minute.
Right.
Third-party payer comes in and says, go to the doctor, we need to go to the doctor, you pay this copay, we pay the rest. The price mechanism is effectively gone at that point.
Right.
And then I'll just go for any little thing that I have.
Right.
On the other hand, if the system is set up in such a way that things are actually more costly than they ought to be, then you underutilize and we end up with shingles when we really could have avoided shingles. So since we're on the Medicare topic, let's take it there and then we'll go forward with it.
Sure.
How do you view Medicare as a aggravator or potential solution to that problem? Or maybe you just want to lay out the whole price problem for us.
Right.
Whichever way you want to take that.
So if you introduce Medicare for all, you're essentially saying you're going to have the government finance all healthcare. Then you're going to run into a problem, and this is where the Medicare for all thing starts to break down for me, is that oftentimes when I'm listening to advocacy for it or reading about it, it's as if people pretend that there's no disadvantage. There's no disadvantage to going to Medicare for all. There are disadvantages to going to Medicare for all. There's disadvantages and advantages to any healthcare system you can possibly imagine. And there's several systems throughout the world, several of them. You may look at some and say, I wish we were more like that one or more like this one, or if we took something from this, that, and the other, etc. Fine. But every system has advantages and disadvantages. And I think it's disingenuous to pretend like every system or that this particular system, Medicare for all, is just like the bee's knees and has no disadvantages. One of the disadvantages of going to totally government-funded care is, what if there's a new treatment that comes out? And before, you could have gone to your private insurer and said, hey, we want this new treatment to be covered by insurance this next year. Now you have to go through a government bureaucracy to ask for that new treatment, and they may not approve it. They may, just give you the want kind of thing in response, and then you'll be mad and whatnot, and then you won't really have any recourse. I mean, you can go and vote every once in a while, but there's no guarantee that through the political process that your voice is going to be heard. So there you have some sort of, heterogeneity of preference, which is fancy speak for saying there's different preferences that different people have throughout the entire United States for their different care and that sort of thing. Those might not get met as well. There's also a known problem of global budgeting, which is that systems in the world right now that do fund all of their care through their government, you eventually run into a budgeting problem. You eventually don't have any more money. And so what are you going to fund and why? And how's that going to be determined? So then you've got an expert panel that's saying, well, we're going to fund this, but we're not going to fund this. Is that the right mix? How do you know that that's the right mix? So you can end up. Now, advocates may come back and say, okay, but one of the advantages is that, the administrative costs will be less. And that's true. You may get rid of the job lock then also. That's also true. And ethically, it's the right thing to do to make sure that we get everybody in and get them treated and whatnot. And right now, we actually do have laws that make it, that you're required if you are sick, you go to the emergency room. They're required to treat you. So it's not like we're right now saying, we're going to let somebody die in the alleyway, so to speak. But there is something to be said for there's increased access if you do have insurance and whatnot. So, but, nothing's free. And one of the things we harp about in economics all the time is what's the next best alternative? What's the opportunity cost? Is that, if you take this on, then it's a serious cost. And there are other things that will have to be pushed aside in favor of, having to finance the care and those sorts of things. You're taking one set of problems and you're replacing it with another. That's essentially what you're doing. You're not going to get a system that's just going to be problem-free. That's a pipe dream.
So let's talk about the administrative cost component. So one of the potential benefits for Medicare for all is the government comes in and steps in and says, okay, well, administrative costs will go down. That doesn't ring true to a casual observer in that we're going to add layers of bureaucracy so that we can scale up a Medicare system,
Right.
which the scale, like they're not going to be returns to scale.
Right.
That's going to get more costly the bigger the system gets,
Right.
just sort of classic organizational theory there. Where would even the proposed reduction in administrative costs come from? For those of us that are casual observers, we're like, what are you talking about?
Right.
That doesn't make any sense.
A typical private health insurer right now is required to, not have any more than, say, 15% of its premiums spent on the administration of processing claims, of, getting premiums paid in, of going out and negotiating with providers and those kinds of things. Medicare, Medicaid are actually more efficient at that sort of process.
Then
Than private insurers, because Medicare and Medicaid, they're bigger. So they can take advantage of their sort of scale to sort of kick those administrative costs down. But again, you're going to perhaps bring the administrative costs down, but that's actually not a big feeder into what's causing the big ballooning in costs. Big ballooning in costs is coming about, arguably there may be some cost disease problem where you just have a resource that's just not becoming that much more productive, and we're just putting more and more and more financing into it because we're trying to get more and more out of it.
So let's break that down,
Right.
because that's a phenomenal point. So I see two things that I want to talk about. You feel free to add any others that you see here. One is part of what's driving the cost is that hospital care is an enormous proportion of that is overhead.
Yes.
And it's scaled to peak use, right? Which is, okay, we have all these bays, we have all these MRI machines, we have okay, what's the most we can need of them at once? Let's have all of them on hand, because like you said, there's an equity problem. Like, is it really fair if 3 people got in a car wreck, there's only 2 emergency bays, there's only 2 ambulance or whatever,
Right.
and so now I got to lay on the side of the road because I had the accident third? That doesn't seem fair, right?
Right.
And so there's an allocation problem there, and the economist in you, it's always ringing in the back of your head, we could allocate this with prices, but we've talked about some of the difficulties of doing that. And then second, you mentioned this specific cost disease idea, and I think there's sort of 2 components, and you feel free to comment on either. One is, as we talked about before, if our utilization of these things for some of these other purposes is going up, well, naturally the cost would be there. And second, I think fundamentally the medical innovation and research, if we're getting decreasing returns to that, but we're trying to keep up that level of medical innovation, that drives up costs. So any comments about any of those 3
Right.
topics?
So just long question. So let me see what I can do to address those
So
different things.
can you comment on the overhead part first then?
Overhead. So what specifically with overhead?
Yeah, so I think, right, my comment is related to this. You see these occasional posts, somebody says, I had knee replacement surgery, or I had 2 aspirin whenever I went to the emergency room, and I looked at my bill and it said $100 per aspirin,
Right.
as if the price of the aspirin was
Right.
somehow unfair.
Yeah.
That's related
Yeah.
to the
Yeah.
overhead, right?
Yeah. So what's going on with that particular scenario is your aspirin doesn't cost that much. What the hospital has had to do is say, okay, we've got underfunded or unfunded mandated patients coming through our doors. Where are we going to get the revenue? Well, we're going to have to charge higher prices to people who come through who can pay for their care. So when we get somebody who comes in who's privately insured, we've negotiated a particular price for the aspirin or whatever it is that is not only covering, say, the average cost of that particular service and whatnot, but it's also covering the overhead and also helping fund the mandated care that has to be covered. Because where else is the hospital going to get the revenue? I mean, it may get some from taxation, it may get some from charities, but it's not going to get enough. It's going to have to fill that gap somewhere, and that gap has to come from people who enter into the emergency room of the hospital otherwise, who have means to pay through their private insurance or whatever it is, and so through that sort of weird sort of amalgamation, we have, essentially, that's the way in which we are taxing people, so to speak, to pay for other people's care. We're already paying for everyone else's care. That's what I want the listeners out there to hear this right now. It's sort of the dirty secret, but we're already paying for everybody else's care, because if you follow this hospital story with me, that's how it's going on. It's going on through price discrimination in the hospital. That's how that's happening.
So I'm really glad you mentioned that. Let's talk about that really briefly. So right now, we're paying for that because anytime we go to the hospital, we pay a little more, right?
Right. Or anybody in your insurance network.
But now I'm making choices about the type of insurance that I carry, the type of medical decisions, the amount of medical care that I consume. Based on that, I still respond to incentives. I still act like that's a price to me, even though you and I both know that it's mangled beyond recognition as far as prices go. And so taxation, you won't hear me advocate for that very often, but it at least have sort of the intuitive fairness of, if we're all paying for it, maybe we should all pay for it, rather than people who need to go to the hospital more frequently pay more than people who go to the hospital less frequently. Because you're implicitly taxing them. There's a pass along of that cost that the market hasn't allocated that, so we don't know that that's the right allocation, as you mentioned before. Neither has the political process allocated that. We're just, okay, now I'm arguing with my insurance company and say, okay, well, aspirin can be $100 and knee surgeries can be $10,000. Well, now people who get aspirin are paying some portion of the unfunded mandate, and people who get knee surgery are paying a different portion of it. And it's like, so now through not having a market and neither allowing the political process to work, we've placed the cost maybe disproportionately. I don't know how the actual prices work out, disproportionately on people who have knee surgeries or whatever. Like that can't, from an equity standpoint, that can't be a good outcome.
It's the outcome that we're with, though, because I think in part because of the political reality. If you go and say, "Hey, we're going to tax you for whatever," that's going to be really politically unpopular. And so we go through this weird charade of saying, "Well, I'm not going to pay for so and so's health care," when in truth, if you follow everything along with this narrative we're talking about, we're already paying for everybody else's care anyway. You may not be the person who is unlucky enough that has to go to the hospital, but somebody in your insurance network does, and you've been contributing premiums to that insurance network. So somebody in your insurance pool goes there, and the vast majority of their bill, with what they're left with, the vast majority of that probably gets covered by the money that's in your insurance pool. So you may not see that money, so it may be out of sight, out of mind, and so psychologically it just doesn't occur. And that's human nature. That's fine. But that money's going in there. We all are already financing care for a lot of other people, whether that person is in our insurance pool or whether that person is someone who came into the ER, wasn't able to pay for anything, and because somebody else in your insurance pool ended up in that ER, they got charged for whatever, and what they got charged and the price that got paid helps to finance not only the person in your insurance network, but it also helps finance that person who came in and was not able to, pay anything for their care. So we're already paying for everyone else's care. We just don't see it.
And there's very little case to be made that there's a way out of that, as it were, given that it seems unlikely you can get to a sort of mostly free market. It couldn't be a free market situation probably, but you can't even get back to a free market situation. So all those problems that you talked about, allowing people to be insulated from the price so they consume too much versus, be insulated from the service so that they bear unnecessary medical cost, that those are a reality. Do you view Medicare for all as potentially having a solution to that, or making that worse?
Well, I mean, like I've said earlier today, when you make a change in the system, you're replacing one set of problems for another set of problems. That's really what you're going to be doing. So the question becomes then, is the net benefit there? Is the benefit worth the cost? And I think, there will be, given how diverse the United States population is, of, we're getting up to close to 350 million people in the not so distant future, 50 different states and the District of Columbia and the outlying territories and all that sort of stuff, and Puerto Rico and everything else mixed in there. The just diversity of people. If you just go to this sort of Medicare for all, one size fits all kind of thing that's going to try to address, medical care for 350 million people and try and, fit all their needs and everything, I think you're just going to end up with a huge, you're going to end up with a mess. And some of the advantages of private insurance is that it can better adapt to what a particular group is wanting to get. So, some of what's being proposed now instead is to just say, hey, let's just take the ACA and put the individual mandate back in place, and just put a public option in there so that we make sure that we got everybody covered, and just leave it at that, because the political reality and the way in which the system has just been set in motion at this point is that you'd be lucky to even get that done. That Medicare for all just politically is just like, I know the Democratic primary right now, candidates are, they're jockeying back and forth and whatnot, trying to get votes and everything. But you forget that there's another big party out there. And to try and get, the conservative party to say, hey, let's go for Medicare for all, that is going to be a very, very tough sell.
Right.
And, we forget that the Affordable Care Act in itself had to have, Democrat control of the Senate and of the U.S. House of Representatives and the presidency, and just barely squeaked through.
Yeah.
And a lot of the ideas in that act actually didn't. Some of those ideas came from Republican administrations.
Right.
So, it's, yeah. I'm probably going a little too far down the rabbit hole there for you.
So let me summarize just a tad bit here.
Yeah.
So Medicare for all has potential benefits and potential drawbacks. The potential benefit is an increase in coverage.
Right.
And I want to say coverage particularly because I want to talk about the access issue next.
Right.
And potentially benefits from the administrative cost. It's not going to, in your estimation, which I think is very reasonable estimation, probably not going to do a great job in terms of matching up preferences, encouraging innovation, and sort of allowing the medical system to evolve into something that meets a wider range of people's needs and wants.
Sure.
Right. And then you've got this option that you're talking about, which is, I don't know if you said go back to, but either get the public option and give more people coverage. Now, I'm saying coverage in particular because the unit had a conversation with a colleague, previous Econ guest, Dr. Pieski, and he mentioned insurance is not the same as access.
Right.
And so my interpretation of him when we said that in our conversation was giving people insurance coverage and then further insulating people from the price considerations that we talked about leads to access problems because there still has to fundamentally there has to be rationing of the medical care.
Yes.
And if there's not a price mechanism to do that, you will get overuse. You will naturally have an access problem. So two-part question. One, did you interpret that the same way?
Mm-hmm.
And two, would you have anything that you would add or change related to that idea?
So, look, just because you have insurance doesn't mean you're automatically going to get access. So, for example, let's say you have Medicaid, but Medicaid payment rates in your state are rather low. Well, then that doesn't necessarily guarantee you access, right? Now, provided you're paying enough through whoever your insurer is, provided they're paying enough, then you can relatively get better access that way than if you are, quote, uninsured. So generally speaking, if you are insured, you generally tend to have better access because you are better assured that you have said access and whatnot. Whether that plays out for you, though, given specific circumstances, be careful with that. The only other thing that I would say related to comments, that I saw there, is, I think of the Rand health insurance experiment in the 1980s. Big study was carried out, randomized sort of thing, in which they looked at different types of insurance. Like let's give you insurance that basically just covers everything. You have no out of pockets. Let's do insurance that has sort of a high deductible where you're actually having to pay a lot out of pocket and whatnot. And let's see how much people use care. Well, when the care is quote free, meaning you're not paying anything out of pocket directly, yeah, there's overuse of the resource. That being said, there's probably underuse when you have high deductible and you're on the hook for a lot of it. Now, what could help is if you had pricing transparency and easy to understand prices. So there's currently a rule under review that may come to fruition of making it so that hospitals have to publish all their prices. Well, that's fine, but I may not even understand all of the different prices that a particular hospital may publish because they may break things down, itemize it by every particular service or whatever else to the point where you can't understand what it is you're paying for. No. So that's like a big difference between, say, going to a steakhouse. If I buy a ribeye steak, you don't have to be an expert to know sort of what you're getting with a ribeye steak. You can, experience it and see what kind of quality you have there. But if you're purchasing a quadruple bypass, you probably have no idea whether that surgeon's any good or not. You may not even know yourself whether you need the procedure or not, which, spoiler alert for the audience out there, please get a second opinion if you ever have the opportunity to. When you're looking at something serious medically out there, because I've heard one too many horror stories. I'm getting off a little track.
Can I set that up? Because I mentioned buying steak, buying water bottles, buying shoes, whatever it was I said earlier. You brought that back talking about the steakhouse, and I find that really interesting because, so I heard a couple of economists responding to one of Paul Krugman's latest articles in defense of Warren's version of the Medicare for All. And those economists said, well, this is why this doesn't work. Imagine, let's go through a thought experiment. Instead of going to a steakhouse and you pay the bill, you go to a steakhouse and you give them your steak insurance card, and then the steak, and then so how much steak are you going to buy? How often are you going to go? Of course, you'll make bad choices on that front. And I think sort of the underlying, if the point they were trying to make is no further than to say this overuse, which you've eloquently discussed already a couple times today, if that's where it stops, fine. But as an economist, I recoil at the idea of treating medicine in this way because we understand some of those fundamental ideas. Now, you just said, okay, get a second opinion. You don't know what a quadruple bypass is. Very difficult. I know exactly when I need a steak because I'm hungry and I go, I want a steak.
Yeah.
And if I go to a steakhouse, we're fortunate to live here in Amarillo, Texas, and there's a good steakhouse on every corner. And I have my preferences. You have your preferences. After the show, we'll compare notes and rank our favorite steakhouses. If I go there and I have a bad experience, I just don't go to that steakhouse again.
Right.
And there are some steakhouses in town that are okay, but I don't like them, so I don't go to them. And then there's other steakhouses that are my favorite. And so when it's my birthday or my anniversary, I talk my wife into going out for steak, we go there.
Right.
So there's sort of two elements there. One is what you've already hit the nail right on the head, which is I know exactly what I want out of a steak, and I know when I do or don't get it. What about that second element of like, okay, but I get repeated interaction, right? So a game theory standpoint, it would be this repeated game idea. What's the role of that in medicine? Do you see a role there, or am I too far down the trail?
If you want to talk about repeated interaction, I mean, if you're going for a routine physical or something like that, it's not as high stakes or so to speak, where you're going to repeat said activity.
Right.
You can get to know that in terms of you can get a better idea as to whether you're getting quality interaction there or not. But let's say you need a liver transplant. You may not know the first thing to know whether you're getting a good experience or not. You may just get a referral from your physician. You've got a huge information asymmetry problem there, where the physician providers know way more than the patient, presumably.
Can I? I don't want to frame this as pushing back on that.
Yeah.
I'm not entirely sure that's even true. So I had an experience, not this past summer, but the summer before, and I had an ear infection. And I went to the urgent care, and I saw one doctor, and then I went back, and I saw another, and they wanted imaging, and I saw stuff, and they didn't communicate very well with each other, and then they wanted to send me, because I had some bad reactions to the medicine, they wanted to send me to the gastroenterologist, and he walks in, he sees the chart, he looks at me, he reads the chart, he says, so you have XYZ, right? I want to see your blood. That was a whole interaction, right? And I'm like, you don't know anything about my case, right? Then I go over to the ear, nose, and throat doctor. She's phenomenal. She gets the story, she reads, she puts the piece together. It's just like watching a detective work.
Yeah.
And I'm like, I'm not even sure. And bear in mind, this whole time I have a GP who happens to have been out of town. He didn't know anything about this until 6 months later we have a checkup.
Sure.
So there's this huge informational problem even on the provider side.
Yes.
That's sort of outside of the scope of what we're talking about today. I don't think Medicare for All sort of fixes that, or probably, I doubt it makes it worse either.
Right.
So I'm not trying to attack the point that you said. Okay, well, they know more. They almost for sure know more. Except in some cases, they don't know that much more.
In some cases, you have to be careful. And go back to the second opinion thing. You got to be careful with who you're getting care from. And you got to be careful if you're, say, trying to look up statistics on a particular provider. Does so-and-so have such a rate of patients dying on their operating table because they're a bad surgeon?
Yeah.
Or do they have them dying on their operating table because the really bad cases are coming to see them?
They get all the hard cases.
So you really then have to rely on somebody that you trust in the medical profession to give you a solid opinion on who's actually a good provider and who is just dangerous.
When I teach my students some of these ideas, you and I would know that statistical term is selection, right? When I teach my students about selection, I always talk to them about there's a famous surgeon named James Andrews who works on top level athletes. So if you look at his recovery times, and I'm quite sure that he is a phenomenal doctor, but if you look at his recovery times and then you say, okay, somebody had ACL tear and then they're back in 8 months when the normal is 14 months, and if it were you or me, it would be 2 years, right? Is that because he's a phenomenal surgeon, or is that because if you do knee surgery on an economics professor, it takes longer for them to recover than if you do it on one of the best athletes in the world?
Sure.
Right. So it's sort of the same kind of idea.
Sure.
In reverse. So we are sneaking up on an hour here. We've covered so much ground. I do kind of want to bring this in for a landing. And what I'd like to do is, given that we've talked about all these things that you would trade-off, that you would balance between these things,
Mm-hmm.
what alternatives do you see? What path would you recommend we go if going to our steakhouse model of fully free market
Sure.
has these kind of problems, going to this Medicare for all obviously has these other kind of problems, and then I think you mentioned ACA and a public option and whatnot. How would you navigate some of those things, even if it's just general principles, for those of us that are going to go listen to the rest of the presidential debates
Sure.
and have to hear about Medicare for all? Help us at least frame that in terms of the alternatives and how you see the trade-offs.
So I think just thinking about the words trade-off and the word cost. So, every system has trade-offs. Every system has costs and benefits. So no matter what you're hearing in the rhetoric, you have to be honest with yourself about what the advantages and disadvantages are. Now, you may get to a point where you say, well, okay, but I really do think the advantages of Medicare for all outweigh the disadvantages. Okay, but be honest about what the disadvantages are. Let's not just cherry pick data and just, pretend like global budgeting isn't a problem elsewhere in the world. Let's not cherry pick stuff and pretend like, in the Canadian system that, you don't have a situation where you may have to wait longer to get an MRI or a CT scan and those sorts of things. Now, you may be okay with that, but I don't know, given, how we may want things right away, our way right away, just like, Burger King or whatever, that may not fly in American culture. So I would say that every culture is different in the world. I think that our solution, what we come up with, will probably look different. It'll look American, so to speak. And, I would say also this. There's a famous quote from Hayek, or one of the Austrian school economists, basically says, one of the real dangers out there is how much people don't realize that they don't know. Translated just basically means be careful, because you may have all these great plans and these sorts of things, and it's great to try and pursue the next evolution of stuff. But you may not think you know as much as what you think you know. There may be something that when you make one move, it can set in motion other unintended consequences that you didn't mean, and you can end up causing a lot more damage than you ended up helping something. So there's a healthy level of, sort of caution, I guess, when you're looking at changes in the medical care system. Because, you make that one change and then, a year from now, all these other problems emerge. And it's like, well, okay, maybe we should have thought 2 or 3 steps down the road, instead of trying to take a revolutionary approach to just, undo something that's already been set in motion. So looking at all the options out there, I mean, me personally, I kind of think that the next evolution is going with a public option, with the reinstituting of the individual mandate, just given the political reality, the history of medical care reform, and the goals of what seems to be going on with people who are in the system and whatnot. That seems to be the most feasible, and it seems to be where things are heading. Free market sorts of stuff. If you push more for a free market, that can come with, and now where you can put in market mechanisms, sure, do it. If you can do pricing in medical care that's both transparent and easy to understand for certain types of care and whatnot, do it. It would be very advantageous for us to be able to easily shop. Right now, we do sort of our shopping through managed care insurance that some of us may have. The managed care provider just goes out there and does all the sort of shopping behind, the closed doors, so to speak, that many of the rest of us cannot, or don't have the time to do by making lots and lots of phone calls. But, just looking at all the day in, day out stuff, human nature, all the different factors, everything that I've read, studied, taught healthcare economics for almost 10 years now, it just seems like that's where things are heading. And I know that may come with its own drawbacks and whatnot, but that's where it seems where we are. And it's going to be sort of an amalgamation. There with the public option, you're going to have Medicaid, Medicare, public option, private insurance, employer provided, not employer provided, exchanges. You're going to have this sort of funny amalgamation of things you're going to look at and say, that's truly American. It's different. It's differentiated. It's taking some different ideas from some of these different systems around the world, and it's sort of saying and making it its own. We'll see what happens.
My guest today has been Dr. Neil Meredith. Neil, thank you for joining us on the Econ Buff.
Thank you for having me.